So one question is, somebody asked about that they have family who may be affected and they live in Burnaby, and can they still access service at St. Paul's Hospital?
That sounds like that's on. Okay. Do I need to use this? Yeah?
We're going.
Oh, okay. Certainly, Burnaby, actually, patients in Burnaby have access to the Tri-Cities Eating Disorders Program, which is now called, I believe, the North Fraser Eating Disorders Program, which is located in Port Moody. So that would be the sort of regional program. But people from anywhere in the province can access treatment through St. Paul's Hospital Eating Disorders Program. So our referral, again, can be initiated through a family physician or through a regional program. And there are criteria for determining the patients that we do see, because we do provide specialized service. So most times we're trying to treat the people who have the most severe illness, but we will see most people for assessment and recommendations about treatment, even if we're not going to be the primary treaters.
Okay, another question somebody had was, as a parent, how do you handle or how do you approach it when you're noticing that your child may be having some binging, purging behavior and consuming large amounts of sweets, and then you're aware that they're vomiting, and how do you approach that with your child? It's probably a difficult situation.
Shall I go ahead?
Why don't you start, Sam?
I will start. It's a very difficult position for family members to be in when you become aware that behaviors like that are happening. One of the problems is that people who have those kinds of behaviors, the patients that we see who do purge, it is a very shameful behavior, and there's a lot of really negative feelings that people have about themselves. So drawing attention to it or becoming angry or frustrated about it tends to worsen it. So I think it's a matter of being supportive, recognizing that this is not about food. It's not about saying just stop doing that, because that behavior is doing something. It's a hard thing to look at, even for those of us who work in this area. It's hard to engage with patients and say, so what are the positive things about your eating disorder? What does it actually do for you? Because we always want to see it in a negative light and have it be something that we want to take away from people. But if it wasn't doing something, people would stop doing it. It's like if you were hitting yourself in the head and you realized it hurt, unless it was serving some purpose, you would probably stop. So the eating disorder serves a purpose, and it's very difficult to watch it happen, but trying to provide some support. There's really great resources. The Kelty Resource Center online has resources for families. We do a family and friends education group that anyone who has a family member who's been referred to our program can access. It's a day-long meeting that helps people understand what eating disorders are and what kinds of approaches are helpful.
I was just thinking for families who are able to openly discuss this with their children or their adults living with them, just some practical tips. When someone is binging and purging, and after they have purged, there's a couple of things that will be helpful for them. Is to just try to encourage them to drink water, and I usually say 2 cups of water after any time that they have purged, and that's primarily for replacing the volume that's been lost after purging or throwing up. Now, other things are health with teeth. If you can talk openly, just to remember that with the purging behavior, they will need more dental care, and to try to, if at all possible, avoid brushing teeth right after purging, to take a break from that. Even though that may leave you with a bit of an acid taste, it will be more helpful for long-term dental health. Those are some practical tips.
Another person has asked, and I know you've partially answered it, but maybe there may be other aspects that you might want to explore or talk about for the audience. How can you help as a parent and strategies of communicating. In this example is a daughter who they believe has bulimia and is very resistant in seeking help or treatment from a medical doctor or psychiatrist. How do you help move them to the next place?
I'm trying to encourage Dr. Rauzus to speak.
She's in pre-contemplation.
She is, yes. Again, it's a very difficult situation to be in, but if there is an opportunity just to have some open dialogue, that is, we've noticed that there are certain behaviors happening that we're worried about your health, and trying to frame it as concern and worry, because so many people will sort of experience any comments about it as being someone being angry at them or them doing something wrong. So really trying to address the issues as a concern about health and well-being, to be looking for other things such as depression and anxiety, because sometimes those are easier for people to identify and accept help around. So oftentimes with people who have bulimia nervosa, depression is very, very common, and it's often easier for them to think about getting some help around depression and improving their mood than necessarily addressing their eating disorder right away. And again, I think being aware and ensuring that your daughter or your child or your partner or whoever in your life you are concerned about, having them know that you are aware that something's happening and that you have concern is the first step. And just ensuring that you're there. I mean, that sort of fits with the motivational enhancement model or stance, which is just being curious and being open and being non-judgmental, which allows people to say what they need to say and share their experience and be able to reach out maybe for help.
Another question pertained to the malnutrition and around, the brain problems that people experience. And once a person is approaching a better weight, can this be reversed? And how long does it take? And
I'm just going to make one quick comment about
Sure.
that. Dr. Rauzus and I are really interested in this aspect and about how people's thinking changes from when they come in and they're malnourished to when they're actually refed. So we're looking at a research project to look at specific cognitive tests for patients when they come into our unit, and then a few weeks down the road to see how those improve. Our clinical sense from working with patients is that it does improve. We don't do a lot of imaging of people's brains, so we don't CT people because of the risk associated with too many CT scans, but I'll let Dr. Arseneau speak to malnutrition.
Sure. Like Dr. Kelleher said, we don't usually do scans. It's not something that we follow that way, but certainly from having patients come in, it reverses pretty quickly. And it reverses along with the weight gain and the increase in body fat percentage. So we often see remarkable gains within a week or two after admission. We definitely notice a difference. Most of the time, it's completely reversible.
And just to add on to that, in terms of when we're talking about cognitive, what you see as an individual within family members, the slowness that we discuss, but what we see when we help someone nutritionally is that their motor function improves, their ability to walk, talk, their speech improves, their thinking improves, so all domains of cognitive. Now, the one aspect of cognitive or thinking that may not improve in the chronic patient population is that there may be a long-term memory impairment, and we definitely do see that anecdotally in our patient population. So you're looking at seeing individuals that have had problems with starvation for 20, 30 years who will have what we see as what would be early cognitive impairment, younger than you would expect in an individual.
So the next question is around vomiting, and can it damage the intestines to the extent that they become so thin and you can feel them through your abdomen when you're feeling your skin? I'm not sure if it's just vomiting in and of itself, but it may be also the weight loss and the sequelae of that.
Okay, so with regards to the question, I think there's two parts to it. With vomiting, definitely there can be increased risks. Fortunately, the risks to the intestinal system are minimal, despite multiple episodes of purging. So if you start at the lower end, at the esophagus, what you typically see is irritation and redness, and that will manifest as chest pain. You very rarely can see tears in the esophagus, and very, very rarely you can have air tracking from the esophagus into the chest. Now, that's very uncommon. Now, as you go up, you again will continue to see erosion, and you may, in the esophagus, so redness or irritation, and the main manifestation of that is chest pain, or other people will say heartburn. The other issues that you see as you go up the GI tract is vocal cord changes. So you'll see someone who's been purging repetitively will have a hoarse voice. So their voice will change as the purging goes on, and it's because of irritation and redness of the vocal cords. So in terms of the GI system as well, you'll get parotid gland changes that are large parotids that come with overactive salivary glands from purging. That sometimes isn't reversible, in that with time you can get chronic inflammation and scarring in the parotid glands. So there may be a bigger gland on the side and underneath the chin. Now, the second question is, I think, if I've got it right, is what's the effect of thinness on the bowel function or the bowels themselves? All organs with time lose muscle function, and the bowel is no different than any of the other visceral organs. So if you have a thin body that's much thinner than it should be, you'll also have a thin bowel. So does that manifest in things that we can see? Well, typically what you see is constipation and a bowel that moves very slowly. And that's adaptive. That's an adaptive mechanism to deal with starvation. Does that reverse completely with refeeding and renourishment? Well, that's debatable. When you look at populations of individuals that have had long-term eating disorders, and you ask them 40 years later, so the children's population, and ask years later, they may still have bowel, quote-unquote, issues, in other words, chronic constipation or bloating. But you have to keep that in context of the whole population as a whole, because many other individuals within the population have issues with their bowels as well. So you can get a lot of recovery with bowel function, with refeeding and repeat nourishment.
A question is, why is the rate of recovery so low? And following up to that, does the length of time living with an eating disorder, say more than a decade, lower the chances of recovery versus someone who's been treated earlier and maybe have had a response?
I don't think we know fully the answer of why the rates of recovery are as low as they are. I mean, certainly from my perspective, I'd love it if I could stand up here or sit here and tell you that, we have a 100% recovery rate in our program. We have a very good program, but we don't come close to that. It probably is because it is such a complex disorder, and because it affects so many parts of people's lives, that it doesn't recover as well. I think also we're searching for, the most specific treatments. Some of the treatments we have are non-specific. Obviously, renutrition is specific, but if the, part of the illness is the thoughts about nutrition, it becomes hard to take that in. So we're constantly sort of battling with people against those kinds of thoughts. In terms of the recovery, there's sort of two times where recovery does tend to happen. So early in illness, so oftentimes that's in the adolescence. So in looking at the program at BC Children's Hospital, they treat children and adolescents. And oftentimes, if you start to treat someone early and the duration of their illness is less than a year or two, and they have intensive treatment and they're able to engage, then their recovery is quite good at that stage. And then typically sort of after about 6 years of illness, which is a really, really long time, people tend to have another peak of where recovery happens. And it's unclear exactly why it is, but it seems that there is a period of time where people sort of end up in this stable, unwell state. And oftentimes it's people decide that, you know what, this isn't the life I want something more than this, and this pushes them into more of an active phase of recovery.
Follow-up question was usually what brings a person with eating disorders to hospital? Is it precipitated by a crisis or heart problems? Like, why are they coming to hospital?
I'll approach it from do you mean hospital like emergency? Like why would someone end up, or?
Probably emergency, and then the next question would probably be who needs admission?
Okay. Because people come to hospital in our program in a structured, sort of predetermined way. So people who are assessed by us when they're coming into hospital, it's typically a planned admission. So they come directly to our inpatient unit. So the reason they come in is because we've made our assessment and determined that they need to be on our specialized unit, and so we will admit them to hospital. From a psychiatric perspective, sometimes our patients will present to the emergency department because of worsening mood symptoms, suicidal thoughts, or an attempt at suicide, or self-harm behaviors that have been quite significant and potentially life-threatening, or other psychiatric symptoms if they have schizophrenia or bipolar illness, that there's been a worsening of symptoms. So from a psychiatric standpoint, they may present to hospital because of those issues, and then typically are treated by psychiatry either on the general psychiatry unit or they come to our unit. And I'll let you guys address medical.
Well, the patients who are brought into the emergency and that we see and admit to the medical wards usually fall under a couple of categories. One of them is severe electrolyte disturbances, so their potassium especially may be dangerously low and they need to come in for that. Along with that, some of them come in with fainting spells where they're severely dehydrated, or they have chest pain or abdominal pain which needs to be looked at. But one category of patients that we admit are patients that we see in the clinic who we talked about, the chronic patients that we follow for a long time, or patients that have medical problems. If their weight falls below a certain threshold that we think is unsafe for them, we try and get them to agree to come in. But sometimes if they're at risk, we may bring them in under the Mental Health Act, which means that they're certified and that we can treat them even if they don't want to. And we reserve that for the patients that we are really worried that if we allow them to continue, that they're at risk of severe complications or death.
A question is the slowness in thought to speech evidence that the patient's in a later stage of an eating disorder, like severely malnourished?
It doesn't tend to be, well, severely malnourished, yeah. It depends on what you mean by stage. If you mean by stage in terms of how long they've had the eating disorder, or to us it's more a severity of malnutrition. So we tend not to see it until people's weights are very low or until their BMIs are very low. And for some of the patients that we see, it's actually a weight drop of just a few pounds, 5 or 10 pounds, can make the difference between them looking completely normal to one day they come into clinic and they're just not thinking straight. And so it's really a marker more of severity of the malnutrition as opposed to how long they've had their eating disorder.
And I was just going to comment that, Dr. Rauzus and I are, as I said, interested in this. And so we do some cognitive testing that is really just very basic screening that would be used for people who are suspected of having dementia or other thinking problems. And even in relatively young women, in their 40s, I can say that, we notice that they have scores on some of these tests that would be concerning in someone who is older, that you might think that they had dementia. They will lose points on things like remembering. They'll lose points on things like attention. So we look at that and we can see that they lose a lot of points on these tests because their thinking is so slowed and that they're not able to attend. And those are usually reversible. As Dr. Arseneau said, it's really a reflection of the level of malnutrition rather than the chronicity of the illness or anything like that.
Can you expand more on motivational enhancement model, and that is like practical supportive exercises that can be done by or with family or spouses?
Can you pop up the slide? Okay. So motivational enhancement, as I mentioned, comes from from substance abuse therapy and treatment, and it's really this idea that you try to match treatment with where people are at in terms of their desire to make change. So there's a model of change that looks at people being at different stages. Pre-contemplation is a stage where people really don't think that there's a problem, and so it's very hard to engage someone in intensive treatment if they don't believe there's a problem. In contemplation, people are thinking about change, but they're not exactly convinced that they want to do something about it. Then people move into the preparation for action. So that's where they say, okay, yes, there's definitely something going on, and I really want to know how to go about making change or what change might look like. And then there's people who move into action. So action is, yep, identified it, I've figured out what I need to do, and I'm actually going to start doing some of this stuff. And then it's into relapse prevention. So these are the stages in slightly different terms. So the pre-contemplation is not thinking about quitting. So this is a sort of in terminology around addictions. And then contemplation is thinking about quitting. Then the planning is planning to quit. Staying quit is sort of the action. Relapse and relapse prevention is the other stage that's in there. So one person who was describing this model once said, it's kind of like, someone who lives in a neighborhood that maybe isn't the safest neighborhood. And someone might, in that state, say, yeah, you know what, I don't really see that it's not that unsafe. I'm okay. And so they don't really see that that's an issue. In another stage, the person might say, you know what, I don't feel so good when I have to leave my apartment at like 7 or 8 o'clock at night in the winter. It feels a bit sketchy around here, but I kind of like my place, and so I'm not really sure whether I want to go. But, maybe there's something going on, and maybe I could think about doing something. The next stage is they say, you know what, totally sketchy, not happy, I don't even feel good when I lock my door, I've now put a second deadbolt, and this is not feeling good. I really need to start looking at Craigslist and find myself a place to live. So that's the planning, and then the action is, okay, I found the place, I've gone and I've looked at it, and I'm going to move, and I'm going to keep myself safe. So those are sort of how people move through those stages. And what we know from working with people who have addictions and working with people who have eating disorders, if someone's in that pre-contemplation phase, so they come in and they tell me during the assessment, you know what, I'm only here because my parents are worried about me. I don't have a problem. I don't want to talk to you. I think this is a bunch of you-know-what, and this isn't really where I want to be. If I try to say to them, you need intensive treatment, boy, do we have a residential program for you, we're not even speaking the same language. We're not even able to engage because they're not even thinking there's a problem, and I'm telling them there's this high-level solution that means that they have to be very engaged. So we start to work at the level that the person's at and say, okay, so you don't think there's a problem. Why do you think your folks think there's a problem? Like, what is it that's going on? Why are they worried about you? What do you think they're seeing? What have they said to you? How is that coming across? What about your friends? What about school? You know, trying to find some places where you have some ground to talk about the fact that there is actually a problem. One of the ways that I help to point out problems is, even though I don't do the physical exams, the internists, my colleagues here do that, I talk to people when I do their assessment about physical symptoms. And when I have a 22 or 24-year-old woman who says, oh yeah, I get chest pain when I exercise, and I get these funny beats, you know, and I can feel my heart thump, and, you know, my legs get really crampy, and I get dizzy. I say, you know what, that's not normal for a 22 or a 24-year-old. What do you make of that? What do you make of the fact that you get chest pain and you're 22? So trying to introduce to them that even though they don't see there's a problem, that I see there's a problem. And so we start to work at that level and help engage patients and keep them with us until they're able to move into phases where they can engage in more treatment. As Dr. Arseneau was pointing out, sometimes we can't wait for that. When people are medically compromised or psychiatrically compromised and we don't believe that they can make decisions and they can engage with us, my saying is you're voluntary until you're involuntary. So I will work with you and I will do whatever I can to engage and help you stay with our program and stick with treatment that we know helps and works. But when you can't do that and when I can't believe that your brain's working well enough for you to make that decision, then I'll make the decision for you, or one of us will. So I hope that answers the question about motivational enhancement.
So another question's about an anorexic daughter who's received intensive treatment for very low body weight, and then she returned back to college after this was successful, but unfortunately is now faltering again, and she is out of town, and so the family's wondering how can we support her. And you know, the question that must run through any parent's mind would pulling her, encouraging her to come out of school and bringing her home and trying to get her engaged in supervision and treatment and help. So just what are the strategies in this very difficult time when you're farther away from them than living in the same city?
It's very difficult, and we come across this a lot. And, you know, I think it's a family decision about whether someone returns from school or doesn't return from school. We see a lot of young women who are brought back from school, whose, you know, folks live here, and they come into our program, and we treat them here because the reality is that they may be putting their life in danger by staying in school and not actually accessing treatment. And then they're also putting their academic career and their future at risk because you can't continue that. At some point, as Dr. Arseneau has talked about, you know, the body's reserve is gone. There's not enough there for them to continue going on. If they're in a major center, there are a lot of the university student health services do have connections with eating disorders programs. So if people have specific questions for me afterwards, I can talk to them about what resources might be available. And certainly I've liaised with some of the other programs in the country and talked to people who work at various universities in terms of providing services. Having been to Toronto General Hospital and their eating disorders program, we're the two probably biggest provincial hospital-based programs in the country. And their program is a fair bit different than ours, and they don't do nearly as many medical admissions. And so we're much more aggressive when it comes to treating medical complications and getting people into hospital quickly. So there's some differences that way, but I'd be happy to talk about specifics if people want to talk to me afterwards. So I don't know if you have anything else to say about it.
Just a couple of practical things is there's always student health that's available if you can engage your relative in going to student health. And then often the physician that's involved in student health can be the spokesperson in terms of liaising with other health professionals within their area or within the community that they've come from. All universities will provide medical exemptions for any student so that they can take a break from their studies without
being penalized.
Penalized, basically, yeah. So we often facilitate and help with that.
Are there any other questions? So what I'd like to do is thank our speakers for a very interesting and informative talk, and I'd also like to encourage you, because this will be up on the website as a AV podcast, so this is a very important issue. If you can let other people know that may have loved ones who are experiencing challenges with eating disorders, to get this out, because I think there's a lot of information that's very helpful. The slides are also available for viewing and I believe download. So just the maximal dissemination we can do to help make people aware of how to deal with this. And I think also I want to thank you for your questions and for the panel for responding, because it was very informative and helpful. And I also invite you to have a few beverages, some cookies, and talk to us before you depart if you have a bit of time. Okay?